Hi, this is Dr. Don Bonner. I'd like to thank everybody for joining the webinar today. Um, please bear with me just a little bit. This is the first time that I've used this particular software. So I'll do what I can. So the name of today's webinar is The Art of Balancing Hormones. And that's me, Dr. Don Bonner. And there's a picture of me. And that's actually out by the water, by the reservoir here locally. And I do like being by the water. Just a little bit about me, real quick. My biography, I'm an osteopathic physician, and I got my osteopathic medical degree in 1991. I did an internship in 1992 in Iowa. I did my anesthesiology residency at the University of Mississippi Medical Center here in Jackson, Mississippi from 1992 to 1995. I'm board certified as an anesthesiologist from 1995 to the present. I've been a practicing private anesthesiologist since that time. And I've also acquired a board certification and advanced fellowship in metabolic and nutritional medicine. So that's kind of where we are today. I embarked on that journey about 5 years ago. And the main reason I did it was because I frankly, I enjoyed the medicine. There was a lot that I didn't know as far as, hormonal therapy and nutrition. There was just an awful lot there. And it's been a wonderful experience. And I hope I can impart some of what I've learned to everybody today. So what I like to do is when I talk to somebody in the clinic, I tend to look at medicine and wellness, and I kind of reverse engineer things. So the first thing I do, believe it or not, is I look at the things that basically can end our life at an early age. And if you look at mortality statistics from the CDC on people that are older than 40, that are non-smokers and not suicidal, the top four things that can end your life are number one, cardiovascular disease and cerebral vascular disease or stroke, which is by far number one for both men and women. Number two is cancer. Number three is neurodegenerative diseases. And number four are accidents. So the majority of accidents on people age 40 to 70 plus is going to be motor vehicle accidents. And then after that age, believe it or not, it's falls. So when you fall at an older age and you're weaker and you have osteoporosis and sarcopenia from loss of muscle mass, and you break a bone, it can be very, very life threatening for you. Main thing I want everybody to really look at are these, especially these top three. And like I said, cardiovascular disease is by far the number one problem for both men and women as we age. And part of what I do here at Personalized Wellness is that I change lifestyle, nutrition, stress management, sleep, all of these different things that that are going to help prevent cardiovascular disease and neurodegenerative diseases also and cancer. So this is what I'm talking about. These are the levers that I feel that we can pull to affect our health, to really to alter these things that potentially could happen in our life. So all of these I address when I see a patient in the clinic. Diet and nutrition is always, number one. So we'll go over that, my philosophy on day one. Sleep's huge, and I think everybody has seen, recently with the lay press, that it's becoming much more of an issue, and people are much more in tune to this idea of how important sleep is. Stress management, again, very big. Exercise. Exercise for me, especially as we age, people need to realize that they have to do some resistance exercise. They have to build muscle. It becomes very, very important. And we'll talk about that in this talk, because proper hormonal management helps you build and maintain muscle. And it's a huge factor in aging. And there's number 5, hormones. And that's what we're going to be talking about today. It's hormones. So let's begin this talk with hormones. And what I want to do initially is just go ahead and talk about the elephant in the room when it comes to hormone replacement therapy, and that's the idea that hormone replacement therapy is going to harm you and give you cancer or cause you to have a stroke, or I've heard it all, blood clots, increased risk of coronary artery disease. There's just all of these fallacies out there when it comes to hormone replacement therapy. And the majority of those come from this particular study right here. This was the Women's Health Initiative, which was launched in the 90s. It was a huge study, and it followed women that were taking hormone replacement therapy. And the purpose of the study was to demonstrate that by taking hormones, that women had a decreased risk of cardiovascular disease. Well, in 2002, the study had to be stopped because, as you can see here, there was an increase in stroke, there was an increase in heart attacks, there was an increase in breast cancer, increase in clots, an increase in dementia. So they stopped the study prematurely, and physicians, patients, women were just completely taken off their hormones at that time, and basically no questions were asked. Well, the big problem with this study, there's actually many problems with this study, but the number one problem with this study is that it was absolutely the wrong hormones that were tested. Prempro was the hormone, and Prempro is a combination of Premarin, which is a conjugated equine estrogen, meaning it's from pregnant mare urine. So it is not bioidentical, number one. The other hormone in this combination was Provera, which is a synthetic progesterone or progestin. And again, this combination was given by mouth, which is, again, the absolute worst way that you could give these drugs. So that's number one, that, of why this study had problems. The next problem with the study is that the median age of the women in the study were actually 65 years plus. And what we know now from with hormone replacement therapy is that it becomes very important for women, as soon as they go through menopause and their estrogen levels drop, for them to get replacement with estrogen, because they almost immediately start to lay down plaque in their coronary arteries, which they hadn't done prior to that point. And we'll go over some of those statistics in a minute. So that was a big problem. So these were women that had been without hormones for a very long time, and the majority of them probably already had coronary artery disease before the study even began. A couple of interesting things about the study, however, was that if you actually looked at the women in the age group of 50 to 59, they actually had a decrease in cardiovascular events. So as you can see, when the study participants were younger and were given even PermPro, that they had a decreased risk, and that was because they hadn't started to lay down plaque in their coronary arteries. Another interesting aspect of the study is that there was an arm of the study with women who had had hysterectomies, and so they didn't need the combination of PermPro, and they were just given Premarin. And interesting enough, they actually had a decrease in breast cancer in that group. And with Premarin, which is a synthetic hormone given orally, so both of which we don't do. The real major culprit of this study was Provera, and that's what I want people to understand. Provera as a synthetic progestin is not a good hormone, and it causes coronary vasospasm, which means the arteries spasm, which obviously is a problem. Increased breast cancer, again, increased cardiovascular events, blood clots. I mean, it was everything about Provera is not good. So that's what we were left with after 2002. And so after that time, there's been numerous studies that have come out, which have shown that in this particular study, this is a Nurses Health study, which was a huge study. And this study showed that estrogen plus testosterone showed no increased risk of breast cancer. And one of the things that we'll see in just a few moments is that testosterone is actually beneficial for the breast, and it actually decreases your risk of breast cancer. So that's one reason why I'm an advocate of women getting testosterone replacement. This is another study that showed that non-oral, which is what we talked about earlier, testosterone prevents the stimulation of breast tissue and lowers the risk of breast cancer. So testosterone definitely has an advantage for us and is protective of the breast. Again, this shows that there are hundreds of studies that shows that testosterone is delivered by pellets, which are bioidentical, and estradiol rather. Both of those together, they do not increase the risk of breast cancer. So, I really want my patients to understand that when we're replacing their hormones with testosterone and estrogen, we are not increasing the risk of breast cancer. And we're doing many, many good things for the patient, which we'll discuss, a little more in depth in just a moment. But quickly, just off the top of my head, we're helping to prevent dementia, which everybody's worried about. We're protecting the breast for our female patients. We're decreasing cardiovascular disease. We are not increasing clotting risk, and we're increasing bone formation with our patients, and we're increasing muscle mass. So all of these things very, very important as we age. Okay, real quickly for our men patients, there was also, even when I was in medical school and many years when I was in practice, we just felt like testosterone increased benign prostatic hypertrophy and increased prostate cancer. And what we know today is that testosterone definitely does not increase prostate cancer. There's just numerous studies that have come out, and one of the main researchers in this is out of Harvard. He's done tons and tons of studies that have all shown that testosterone does not increase your risk of prostate cancer. Okay, so now that we've gotten that out of the way, and I've gotten some of the fear out of replacing your hormones, let's talk about how we can replace the hormones and what they actually do for us. So this picture shows a couple of pellets. That looks like probably that's a testosterone pellet and probably an estradiol or estrogen pellet. But as you can see, they're very, very small. And these are implanted in your bottom, and they last for women 3 to 4 months, for men a little bit longer, 4 to 5 months. And you don't have to do anything. They're implanted. There's no gels or creams to worry about. You don't have to worry about passing them on to anybody else. So throughout the rest of this webinar, you're going to see that I'm a big proponent of pellet therapy. And interesting enough, I'll throw this in there. I was not a proponent of pellet therapy for quite a while, because the American Academy of Anti-Aging Medicine and all of the hormone courses that I've been to over the years, they really didn't advocate pellet therapy. They felt that it was, a surgical procedure, that it was invasive and just unnecessary. And they advocated creams and gels and patches. And I've used those, ever since I've been seeing patients. And the thing that I've found using those is that it was very hard to get blood levels on my patients. And I know people would disagree with me about that. They'll say, well, you need to look at saliva. There's all these other, ideas about what you should be doing. But what I can tell you for certain is that when I started using pellets, that I started getting very good, stable blood levels in my patients of their hormones. And more importantly, my patients felt better. I mean, so many of my patients, I would have them on gels and creams, and they would tell me that they couldn't tell any difference. And I don't see that with the pellet therapy. So this slide, hormone havoc. So we're going to go into hormones just a little bit, what they are, and kind of how they throughout your whole body. And there are many, many hormones. I mean, more than you can that I can sit here and talk about. And today we're going to be focused on our sex hormones, estrogen and testosterone. But again, many other hormones: insulin, glucagon, cortisol, thyroid hormones, leptin. I mean, there's just many, many, many hormones in our body. And especially when we're talking about our sex hormones, they decrease as we age, and they just do. And one of the main things that I always do when I talk to my patients is I want to know, how they feel. I'm not going to be, treating all my patients just based on numbers. So even if I get good numbers back on my patients and they tell me that they still don't feel well, that just means we have to, search and find out why they don't feel well. And this is pretty funny. Um, so, do you feel like this? I mean, do you have headaches? Is it hard for you to get up in the morning? Are you tired in the afternoon? Um, have you put on extra fat mass, and it's hard for you to build muscle? Um, Fatigue, like I said, is very, very common in most of my patients. And the other thing is insomnia. I see insomnia very, very frequently with my patients. But again, yeah, this is what we want. This is how I want our patients to feel. We're, energetic and happy, exercising, putting on muscle. So this is our goal by replacing these hormones. So these are a lot of the symptoms, like I was talking about earlier. Uh, Fatigue is super common. I would say almost 100% of my patients that come in tell me that they have afternoon fatigue. It's just ubiquitous. um, tension and irritability, anxiety. How many patients do I see that have been placed on a antidepressant in their 40s and 50s? It's just a huge number. It's like physicians, that's one of the first thing they reach for any of these particular problems, including hot flashes, believe it or not. And that's actually recommended by some organizations. I just won't get into that. But again, lack of sleep with insomnia, very common. I just saw a patient today, and we were talking about this: 3 to 4 a.m. wake up, and you wake up and you can't go back to sleep. Memory loss, what we talked about with cognition, depression, the typical symptoms of menopause, hot flashes, night sweats, very, very common. And believe it or not, that's usually due to testosterone as opposed to estrogen. Weight gain, and here definitely decreased sex drive and our performance. I see that in both men and women, but I definitely see it in women. And we'll see in a moment why that's the case with testosterone in particular. Quickly, andropause, that's just the male version of menopause. And again, 20% of males over 50 have low testosterone. And men with comorbid conditions are very likely to have low testosterone. Diabetes, high blood pressure, sleep apnea. I mean, how many men have these conditions? Very, very common. And I think that low testosterone in these individuals is undiagnosed and undertreated for sure. And this is what we deal with here in the United States. Believe it or not, the United States and New Zealand, the only two countries in the world which allow pharmaceutical companies to advertise on the television. And I don't know if you're like I am. I remember the first time they started doing this. It just really blew me away. That I mean, they're almost giving health care over the television, and big pharma is a problem. Okay, testosterone is one of the hormones that we replace here at Personalized Wellness, and again, we do it mainly in the pellet form. Um, I can't say enough about testosterone, what it does for both men and women, and I think that surprises women a great deal. Um, but your brain is affected tremendously. It helps you think clear, helps prevent dementia. Um, your heart is protected from cardiovascular disease, and as I stated earlier, cardiovascular disease is the number one cause of mortality in patients as we age. Um, Protective to the breast for females, and increases bone density in both men and women. And as you can see, men lose testosterone between 1 and 3% per year between the ages of 30 and 70. So a man age 50 could have lost anywhere from 20 to 60% of his testosterone, which is a big number, and that needs to be replaced. But women, look what happens to women. And I find this, just I can't tell you when I've tested a woman who had normal testosterone levels. It's just very rare. And women lose testosterone rapidly as they age. Starting at around age 25, women can lose up to 50% of their testosterone per year. So by the time you're in your mid 30s, you can have very low testosterone levels. And the other real problem I see with women is also with birth control pills, because as you take birth control pills, you increase something called sex hormone binding globulin. And in a nutshell, sex hormone binding globulin binds up the testosterone that you do have, and you're not able to have the free form of testosterone, which is actually the active part that works in your body. So not only do you have low testosterone, you can't release it towards being used anyway. So it's very common to see women after especially after childbirth, their late 20s, 30s. They're on birth control pills, and they have, very low libido and sex drive. So again, here's the positive effects of the testosterone, and I really see this in my patients, like what we were talking about earlier, as far as how do you feel. And I definitely see an increase in energy and vitality. That it's almost like a veil's been lifted, and you're able to think clearer. Uh, you're able to handle stress better than what you did in prior. Again, we've got breast protection, cardiovascular protection, increased bone strength, reduced body fat, enhanced libido, enhanced performance. It just does so many things for both men and women. Quick facts about menopause: 3,500 women enter menopause daily. So, huge number. But the symptoms can actually start up to 15 years earlier. So, somewhere around age 35 or so, I see many quote unquote perimenopausal women, and their hormones are fluctuating, their testosterone's low, and they just, they don't feel well. So estrogen, and this is almost a crusade for me for my female patients. I see so many female patients that come in, and I can't tell you how many I've seen that have had, a hysterectomy sometime in the past and were never placed on hormone replacement therapy, and for a fear of breast cancer. I had a patient today or yesterday that fear of blood clots. There was a fear of blood clots, so she wasn't placed on estrogen replacement therapy. And estrogen does so much for women. Uh, 400 functions in your body. I mean, it's just not a matter of controlling hot flashes. You know, uh, it does so much as far as cognition. It helps you think better. Um, it helps build bone, and it helps protect the heart. That's a huge, huge thing that I need to get across to everybody. That women, once they go through menopause, are at much increased risk for cardiovascular disease, and they need to have their estrogen replaced. Oral estrogen therapy, again, I don't agree with oral estrogen therapy, and especially synthetic estrogen therapy. But see, these are some of the things, some of the problems that you run into by taking oral estrogen. And as you can see, none of them are good. And here are your blood clots, and that's where people get that idea that blood clots are increased by taking estrogen. And but you can have breast tenderness, endometrial problems from your uterus, headaches, vaginal bleeding, weight gain, all of these not very good. And this is really a key that, like I said, it's basically a crusade of mine. And if there's one thing I could do to get this message out to women as they're going through menopause, and to really, really look at this statistic and take it to heart. 1 in 7 premenopausal women die from heart disease. After menopause, that number goes to 1 in 3. So a huge increase in your risk of heart disease. And women quickly catch up to men after menopause with heart disease. And that's why you have to have, or really need to have, your estrogen replaced in the appropriate manner after you go through menopause. So that, there's different ways of replacing these hormones. I talked a little bit about that earlier: pills, patches, creams, and of course my favorite, pellets. And I'll go into specifically why I like pellets in a few moments. Patches, I've used patches in the past, and it's not a bad way of giving estrogen. Um, it becomes kind of a headache. The adhesive oftentimes becomes a problem. I've had several patients um, have allergies to the patches, but it is bioidentical, and it is given by a route that's not going to cause the problems that you get with oral. But again, don't like it as well as the pellet therapy. Creams and gels can work, and you just have to be very good at putting on gels. And if you really look at it when they give these gels out, they'll tell you that you need to rub these gels in for it's many minutes. It's like 4 to 5 minutes. And I've never seen anybody that would rub a gel in for that long. You've got to put them on at 1 to 2 times a day. And the big problem that I have with gels and creams is transference. You can definitely transfer the hormones to other people, children, pets. There's a person I know whose dog was very ill and bleeding, and they couldn't figure out what's wrong with it. And the owner was transferring estrogen to the dog from her gels. So big problem. This is Testum. This is a gel for testosterone. And the main thing I want you to take away from this, I don't want you to get too caught up in the study, but this is 500 nanograms per deciliter is how much testosterone you have in your blood. And as you can see, even with maximal therapy with Testum, you're not able to even get to 500 nanograms per deciliter. And actually, I want that level to be up to around 900 to get maximum benefit. So as you see, you're nowhere close with Testum. Now this slide I think is a little dramatic with testosterone injections. I mean, I've used injections in the past for patients, and they work. The real problem that I have with the testosterone injections are that to really be effective and to work very well, you really need to inject a couple of times a week, more than just once a week. So, and even injecting twice a week, you're still going to get blood levels that fluctuate up and down. So you get kind of a roller coaster effect with the hormones and with the testosterone. And, initially you take it, you get a very high blood level, you overshoot. And then by day 3 or 4, you're going to be at a low level. So yeah, that's the main reason why I don't like injectables. Again, the pellets, they're bioidentical, which means that they have the exact chemical structure of the hormones that you have in your body. Uh, they last longer. The dosage is individualized to the patient, and you don't have to worry about them. Once they're in, you just forget about them until either your next appointment comes up or you start to have some of your symptoms return. And that's generally what I see in my patients. You start seeing some symptoms return, and they come back. Pellets, just by history, they've been around a long time. This is not like something that was just invented. So you could say they were developed in 1939, and very popular way of giving hormones, especially in Europe and Australia after they were developed. But one thing changed that, and that's when Premarin was first manufactured. It was in an oral form and synthetic, so they could make a lot of it. And Premarin took over the market, and pellets went by the wayside. This just shows estradiol levels, the difference between patches, orals, and the pellet implants. And what I want you to see is the stable blood level that you get from really day 3 till, month 3 or 4. So very stable blood levels. So the BioT therapy is, again, it's the right kind of hormone. It's bioidentical. It's individualized. to the patient by their lab work, by their symptoms, by their weight. All of those things are taken into account into a sophisticated algorithm to tell us as the prescribing physicians how much to give. So it's the right delivery system in my mind. Um, Again, it's safe. It's been around for a very long time. Very low side effect profiles with pellet therapy. It is the best method to increase bone density. No increased risk of breast cancer, no increased risk of blood clot, and all of the benefits that we've gone over in the past. Again, osteoporosis, big problem as you age. Like I was telling you earlier, after about the age of 70, fractures are the number one accident that you can have, which can end your life. And as an anesthesiologist, I've seen this for almost 25 years. When elderly patients fracture a hip, it's very important for us to get that person back on their feet and to operate, get them fixed, get them back on their feet. Because if you do not, uh, the mortality can be upwards to 50% from fractures. So fractures are a big deal as we age. So you want to maintain bone density. Alzheimer's disease, we're all concerned about dementia and Alzheimer's disease because we're living longer. We're really good in medicine of keeping us alive those last 10 years of our basically those last 10 years. We spend a tremendous amount of money. We have lots of technology to keep us alive. But how many patients do I see, especially in my anesthesia practice, that are alive but have been demented for many years, and they don't know where they're at. They don't know their family members, and obviously this is something we want to avoid. And hormonal therapy helps avoid this. This was Susan Davis from Menopause. Estrogen replacement with pellets has effects on body fat, so it decreases body fat percentage, decreases total cholesterol, increases HDL, decreases triglycerides. So really good effects, and all effects that we want. And this is interesting. Arthritis, I really see this with testosterone in particular. Um, Decrease in arthritis symptoms and a major decrease in aches and pains and fibromyalgia symptoms. Um, I really, my patients that have those issues really notice a difference with those things. Quickly, this just shows all the things, the benefits that you can get by raising that serum total testosterone to, what I said earlier. 900 is kind of where I want to be for testosterone levels, and this is for a man as far as 900. And this shows all of the benefits that you get, and and then all of the problems that you can have when you drop below those levels. So we need to get our levels up. Quickly, some of the things that can happen when you get testosterone replacement by pellets. The first time we put the pellets in, the very first time, you can get a little bit of fluid retention. I'm not sure exactly what the mechanism of action is of that is. I do know that you're going to build muscle mass, and muscle does take up some fluid. So, but that's easily taken care of and tolerated. If we need to, we can use a mild diuretic to decrease that swelling. Uh, if you have not had a hysterectomy and we replace with estrogen, we're going to protect the uterus with progesterone, but you still can have uterine spotting or bleeding, and that's something that we have to deal with. And unfortunately, there's four causes of that. It can be too much estrogen, it can be too little estrogen, it can be too much progesterone or too little progesterone. So sometimes we have to make several adjustments, and but the main thing is that we don't let that go untreated. And if we need to, we get a uterine ultrasound to see exactly what's going on. Um, you can have pellet extrusions. I see that more with men, pretty rare with women, but you can extrude pellets. And it's not something that hurts you. And if you lose, a pellet, we evaluate you, see how you feel, and if necessary, we can always boost you with another pellet. Females, uh, facial breakout or acne, again, something that's possible with testosterone. I don't see it very frequently, but again, we can treat it. There's drugs that we can use to treat that, and then to get you through to your next pellet placement. And then generally, I just decrease the dose of testosterone a bit. With men, you will get a decrease in testicular size. I don't I don't know why this is a big deal. It doesn't affect any issues as far as performance or anything like that, but it can become an issue for some men. And I tell men that your testicular size is going to decrease by 10 to 15%, and it's just a physiological process because the testosterone is going to cause a decrease in hormone release from certain hormones from your brain, which will cause some shrinkage. Um, this is my clinic, Personalized Wellness. We're located in Ridgeland, Mississippi, Highway 51, Suite D. I'm on the second floor in basically a fourplex of offices. Um, I've got two big, bright yellow Adirondack chairs out of my patio. I didn't plan that, but they are very visible from the highway, and a lot of people find the clinic by those chairs. We've got two phone numbers here at the clinic. The main number is 601-898-0911, and the other auxiliary number is 601-790-9140. Um, Again, I'm a big believer in pellets and BioT. We do a lot of other things here at the clinic besides hormones, and not just your sex hormones. A lot of other hormones, thyroid, vitamin D, which really is a hormone, um, insulin levels, leptin levels. There's a lot of things that we look at here uh, besides hormones, but hormones big part of our practice. Um, for people that are here for the webinar, I've got a special offer for you. Um, when you call and book an appointment with Rachel here at the clinic, and you tell her that you watched the webinar, um, when you give her the words BioT, she'll put you down for your consult, and we'll give you a 50% discount for that initial consult. So that's a $75 value for everybody. And I just say, give us a call. And I'm a big believer in hormone replacement therapy. I'd say it's a mission of mine to get the message out and to get rid of some of these false beliefs about hormones, and let everybody know how beneficial they are for all of us. So that's it for my talk. I've got about 10 minutes or so to answer any questions that anybody may have. So if you have any questions, feel free to type them in, and we'll wait a few minutes to see if any come in. And if not, I thank everybody for taking your time to watch this webinar, and give us a call here at the clinic, and we'll get you tested, and take care of you. So again, I appreciate it. So no questions yet. I'll wait just a minute and answer any particular questions that anybody may have. But yeah, it's kind of interesting, going back that I was didn't really. It wasn't that I didn't like pellets. I didn't really understand the pellet philosophy, and And at my courses that I'd had, the professors that I had and physicians uh, didn't didn't like the pellets, so I never used them. And a good friend of mine was using pellets and was talking about them, and finally I came by to his clinic and watched him put some of the pellets in, and realized that it's really not much of a procedure at all. It's a teeny tiny incision. The needle we use looks very much like an epidural needle as an anesthesiologist, and you don't even put any stitches in or anything. So a couple steri strips over the wound, and the wound heals. And so, as far as being invasive, not really, not much to it. Um, Okay, we've got one question from Christine. She asked, "How long does the pellet appointment take?" Generally, that initial consult is going to be about 30 minutes, and it doesn't last very long. But I have to get a history and physical, from all my patients, and find out, comorbid conditions, and whether or not, I think that, they need the, hormones. Um, and then we also get lab work while they're here, but it doesn't take much more than 30 minutes at all. We can get everything taken care of. But you have to see everybody. You have to do a good history and physical for all patients. But good question. I appreciate that. Well, that looks like it for the this webinar, and I'll put some other webinars out in the future. The other thing that I'm considering doing is doing some Facebook Live presentations. Thursday afternoons is my time off from the clinic, so they'll probably be pretty consistent on Thursday afternoons from either 3 or 4 o'clock, whatever most people want to do, and we'll go into not quite as in depth as we did today, and talk about a lot of different things: hormones, diet, nutrition, weight loss, many other things. But again, I appreciate everybody taking your time to come in and watch the webinar, and I hope you have a good evening. Thank you.